the extrapyramidal side effects of antipsychotic medication. This is just going to be a little bit of information. If you need more information, you have to come for the detailed review by coming to Advanced NP Certification Review Services. So let's dive into how EPS comes by. So normally, smooth muscle, basically they depend on the balance between dopamine and acetylcholine. So when a patient is given antipsychotic medication, what that does is to block the dopamine production. So the moment there is a low production of dopamine, there's going to be excessive production of acetylcholine. Don't forget the fact that in the main review, we've actually educated every student to know that once dopamine is low, acetylcholine is going to be high. The two of them does what we call inverse relationship. The moment dopamine is low, acetylcholine is going to be high. And that's the reason for this abnormal movement. And that is called extrapyramidal side effects. So which medication mostly causes extrapyramidal side effects? So basically, we see that most in patients that are taking the first generation antipsychotics, those ones that we call the typical antipsychotics, those that are ending with the ZINE, example is clopramazine, thorazine. So basically, they are the ones that mostly cause the extrapyramidal side effects. They are generally called the typical antipsychotic or the first generation antipsychotic. We rarely see EPS, little or no EPS, in relation to the typical antipsychotic or the second generation antipsychotic. So basically, we are going to use the acronym of PDATA, PDATA, to remember our extrapyramidal side effect. Let's start with the P. The P is pseudo-parkinsonism. Something that looks like a false parkinsonism is not actually the active parkinsonism. Patient is going to be having a slow movement, stiffness, shoveling gait, pill rolling tremors. It's going to be mimicking something that looks like a Parkinsonism disease, but they are not actually having the Parkinsonism. It is this medication that is making them to have the pseudo-Parkinsonism, a false Parkinsonism. The next one is the D, dystonia. Patient will have a sudden muscle cramp-like movement that is affecting the major muscles of the body, especially the head, the neck, and the back. We also talk about the A, which is the akathisia. Patient will complain of inner restlessness. It actually looks like anxiety to some patients. They're going to say they are very anxious. They are not actually anxious. They're having some uncontrollable restlessness. That is akathisia. And it will not even make patients to be able to sit in one place. They're going to be restless. The last one is the T, which is our tardive dyskinesia. Tardive dyskinesia. Basically, tardive means something that is delayed. A tardive person, someone that is late, is going to be delayed. So most often, the symptoms of tardive dyskinesia appears about months or years after the patient has started taking antipsychotic medication. And the word dyskinesia means abnormal movements, which is affecting mostly the muscles of the face, the jaw. And you see most of the time patients will complain of lip smacking, they'll be having a puffy cheek, you see them having a tongue thrusting, a jaw clenching, and can also affect the eye. At the moment when you see this eye, the eye of the patient rolling, we call that oculogyric crisis. So this one will require more of a medical emergency. The medication, which is the offending agent, the antipsychotic medication, has to be stopped immediately. Most of the time, patients need to be hospitalized for them to be treated for the oculogyric crisis. The very last one is akinesia, which is the loss or severe impairment of voluntary movement. It is characterized by patient inability to initiate movement. It is important to know that there's a relationship between this akinesia and bradykinesia. In exam, they can ask you bradykinesia or akinesia. When the patient cannot initiate movement at all, that is akinesia. So let's connect it in relationship to bradykinesia. Bradykinesia is a slow movement. Patients initiate movement, but it's a little bit slow. Don't forget that. So we can say akinesia is often seen as an extreme form of bradykinesia. So bradykinesia is a little bit milder, while akinesia is more severe. So know the difference between the two. Akinesia, there is no movement at all. Bradykinesia, there is a slow movement. So akinesia is severe, something like an extreme form, while bradykinesia is still milder. So how do we treat EPS generally? We're going to be giving the patient anticholinergic medication. Example is benztropine, digoxin. But it is important to know that we don't want to give benztropine or cogentin to the patient that has tardive dyskinesia, because most of the time it worsens it. We may likely give them Benadryl or the benzos, depending on the severity of the tardive. Then of recent, We have some newer medication that are given to the patient, which is the Ingrezza or the Austedo. Then the patient can also be switched to the atypical medications. For akathisia, patient can be placed on the propranolol, the clonidine, that will also reduce the restlessness that the patient is presenting with. For Parkinsonism or the pseudo-Parkinsonism, we are going to give them dopamine agonists like the amantadine for that individual. So for more detailed content review, this is just a synopsis of what we are expecting students to know about the extrapyramidal side effects. For more detailed content reviews, you can kindly visit our website for registration at www.advancedmpcertificationreview.com, or you can call my number directly 281-372-9148, or you send me a direct message through via WhatsApp or the same number 281-372-9148. This is Dr. Kemi Akinlaon. Thank you and God bless.